Hi, my name is Dr. Autumn Brogan. I'm an emergency physician at Mayo Clinic. I'm the practice chair for Mayo Clinic Health System in Minnesota, and I also am a co-director for the Certain Group, which is an online education platform that teaches acute care topics around the world. It's a pleasure to be with all of you today. My talk is going to teach you today on how you can train better, work smarter, and deliver safer care, even as our workforce is dwindling. This talk is going to provide actionable technologies that you can take away and design and implement for the realities of the 2026 workforce. Before I start, I will share that I have no financial disclosures. I want you to imagine that you are all by yourself. It's 2 a.m. and you have a 40-bed intensive care unit, and you're the only doctor present. You have a junior learner who calls you and tells you there's a difficult airway in an anaphylactic patient. A nurse is also trying to get your attention and tell you about a septic patient with a dropping blood pressure. She needs to know the dose for the vasopressor you're about to order. And somewhere there's an alarm ringing and no one can hear it over the symphony of the other alarms. Welcome to now. The workforce shortage is not looming, it's landed. However, today I hope to share my optimism for the future of the workforce, as I am more optimistic than I have ever been at any other point in my career. And we're not going to solve our workforce issues by hiring our way out. Instead, we have to solve it by training our employees differently, by using technology that already works, and by implementing it well. The way forward is going to be to ground ourselves and understand the problem so that we can look forward. Today, we're going to talk about telemedicine and virtual learning, and then we'll start to talk about the electronic health record and what ways can we make this work for our providers and nurses. We'll talk about artificial intelligence as a model for precision learning, and then we'll talk about simulation, including virtual and augmented reality, and how automation can offset the gap. And most importantly, we're going to talk about how do we implement these things ethically and equitably. The crisis of the workforce shortage spans the entire team: physicians, nurses, respiratory therapists, and pharmacists, and burnout is exacerbating this problem. And we are still largely training people the same way we trained them 20 years ago for a clinical world that is no longer in existence. But the good news is that the COVID-19 era forced us to sprint forward with innovation, and now we know what actually works, and we don't need to go back. So how do we use this to our advantage? How do we use the technology that we've found to be useful and take it forward in our workforce? Consider the Telescope program in Brazil. This is a community ICU without 24/7 coverage with an intensive care physician. The hospital implemented daily virtual rounds instead that were led by a board-certified intensivist, and they paired those rounds with a protocolized e-learning and layered in monthly performance reviews. The outcome? They reduced their ICU mortality and improved adherence to best practices. They didn't do this by adding more staff, but they leveraged the staff that they had and brought it to scale. An expert consensus now gives us a blueprint for how to set up telemedicine in our hospitals, from technology needs to stopgaps in care. At Mayo Clinic Health System, we recognize that the emergency department ebbs and flows, especially with patient visits. 1 hour, you may be saturated with patients, and the next, you're all alone and there's no one there. Thanks to technology and to screens, we now can virtually float our physicians from one hospital to another via telemedicine. This allows us to offload the physician that is physically there working at their capacity and allows the physical physician to focus on procedural skills while the virtual physician can assist in ordering medication and obtaining histories on patients. The American Academy of Graduate Medical Education established formal telehealth competencies for all training levels. And we're not just teaching residents and fellows medical concepts anymore. We're teaching them how to manage patients they can't touch. This allows us to blend asynchronous educational models with synchronous skills practice and immediate feedback. And it works. Studies show that telehealth training amplifies learning. Why? Because when you can't rely on your hands, you must sharpen your clinical reasoning. You learn to gather data differently. You develop communication skills that make you a better doctor, even when you're standing over them on a screen rather than next to the patient at the bedside. But telemedicine education is not just for junior learners. We can also use this to train up our current workforce and to adapt to new skills or new responsibilities. One way of uptraining faculty is by using tele-educational coaching at the bedside. During the start of the pandemic, Mayo Clinic's certain team of intensive care and emergency physicians did just that. They provided assistance in education to physicians working both within and outside the United States, and when the conflict broke out to Ukraine, they offered education to colleagues there as well. Another way that we can embrace technology to teach is to use virtual learning, and that doesn't have to mean Zoom. While Zoom and other online platforms are very useful in how we can communicate lessons and topics to others in the form of recordings or live lectures, there are much newer technologies that can also offload our teaching while still allowing us to provide education in a manner that can be non-biased and time efficient. Simulation medical education has traditionally been an in-person educational activity. And as such, it tends to be time consuming. You have to have multiple faculty members present, and there's a lot of resources needed to run each simulation scenario. Now, thanks to AI agents and our amazing computer programmers, we have developed online tools that can create alternatives to real life simulation. They allow our learners to practice similar skills and allow them to make mistakes and learn in real time. In this slide, you'll see our vital software that we use for healthcare workers, and they can use it to practice running online resuscitations and receive real-time feedback on how they're doing. A third technology that we usually don't think about for education is our electronic health record system. Now I'm going to ask you a question, and hopefully for those of you at home, you'll feel even safer answering this. Raise your hand if you've ever ignored a sepsis warning in your electronic health record. I know I have. They're terrible, right? Yeah, but here's the deal. They're changing, and the computer systems are getting smarter. Modern clinical decision support systems embedded into the electronic health records are starting to get more accurate, and they're not just screaming sepsis every time a patient has a fever documented in the chart. They're providing context-specific and evidence-based recommendations at the moments when you need them. And you can well design these electronic health records. Meta-analysis have shown that when they are well designed, these clinical support tools that are embedded in electronic medical records can have an effect. In fact, they found a modest 5.8% increase in guideline adherence when they were well developed in electronic health records. That doesn't sound too impressive, but when you think about preventing medical errors, ordering appropriate DVT prophylaxis, or catching acute kidney injury early on, that 5.8% can really save a lot of lives. Another way you can use the electronic health records to help patient care is through pharmacy recommendations. Electronic prescribing with integrated decision tools can check for drug-drug interactions, they can adjust for renal function, and they can flag geriatric concerns. They can even prevent allergic reactions. These systems are like having a pretend pharmacist always rounding with you. And with good systems, they can even alert us to new practices or changes in dosing, or even recommend medications based off local antibiograms. Yet, in order to get physicians to pay attention, you have to avoid user button fatigue. We need user-friendly interfaces, customizable alerts based on clinical context, and continuous refinement based off how people are using the tools. And one of the biggest fields AI is helping with is radiology. I watched a radiology resident the other day use an AI-assisted learning platform. She was practicing interpretation of CT chest imaging. She was getting immediate feedback on her reads before she ever showed them to an attending. And she shared with me something really interesting. She said, "I'm not afraid to be wrong anymore because I can be wrong in private first." Now that's the power of AI in training. It can create the safe space for deliberate practice without the psychological stress of public failure. The 2025 systematic review found that 92.9% of studies show AI-based training enhances both knowledge and diagnostic performance in radiology. And the FDA has now approved over 200 radiology AI products for clinical use. At many institutions, including my own, every time a trainee or attending physician reads the film, an AI tool is providing a second opinion immediately. And they're not trying to replace the attending, but they're trying to accelerate the learning cycle. By using these tools, they can create continuous moment-to-moment guidance that accelerates mastery. And that's precision learning, personalized education based on individual performance gaps. However, we must be careful about automation bias. We're not training radiologists to trust AI blindly. We're training them to collaborate with AI intelligently. That means teaching AI literacy, understanding capabilities, recognizing the limitations, identifying bias, and maintaining our primary interpretation skills. In all specialties, we are seeing more simulation, virtual reality, and gaming being adapted into medical education. And here's one of my favorite studies. Pulmonary critical care fellows in an academic program underwent simulation-based training for critical care airway management, and they used a computerized patient simulator for this. So they had them practice, and they practiced until they scored 38.3 out of 40 on a standardized checklist. Then they had them do their first real-life intubation. The score they got was 39 out of 40. The skills had transferred perfectly, and when they tested them again during their second and third years, they were still at 38.7. That means the skills stuck, and they were not losing the skills over time. Online simulation is another way that we can involve online resources when our real physical resources may be limited. This is an example of the CERTAIN program, and here you can use simulation in a virtual environment to teach learners in a continuous, repetitive manner as they master the necessary skills for resuscitation. There are now even virtual reality procedural training for ventilator management, central line placement, intubation, and even ECMO cannulation, all practiced in VR before the learner ever touches a patient. And we're also seeing metaverse applications for immersive learning, gamification of clinical concepts, mobile learning platforms, and AI-powered adaptive systems that adjust to each learner's needs. And patient care can see direct effects as well. There was a study of patients undergoing cardiac surgery who first experienced VR simulation of their ICU stay. And when they actually went to have their stay, they noted that the patients who had done VR simulation ahead of time had shorter sedation times, less time on the ventilator, and less anxiety. The technology can help us with our declining workforce. And the hard truth is that we will not be getting more people, but instead we can train them and we can work smarter. AI and automation are now handling administrative tasks such as documentation, order entry, or discharge summaries, and it frees up our clinician time for actual patient care. We also can use it for remote monitoring, where we have continuous surveillance of vital signs and intelligent alerts when patterns suggest that a patient is deteriorating. We can also use it for task shifting. Digital tools enable nurses and clinicians to focus more on medical skills and leave mundane tasks such as charting to the robots. So how do we implement these sorts of changes so that they work for our system? Thanks to technology, we are growing our workforce through machines and able to expand our critical care expertise in resource-limited settings. So what's the solution? Well, based off of the evidence, here's what works. You need to do a needs assessment before you ever go out buying technology. You need to know what the problem is and understand it fully from all the stakeholders before making a decision. Learners, faculty, administrators, and IT, everyone needs to be at the table from day one. You also need to make sure that you have adequate infrastructure and support for the project you're imagining. The fanciest VR headset is useless if nobody knows how to turn it on. And you need a process for ongoing evaluation. What works today may not work tomorrow, and you need to build this continuous quality improvement system into your work. You should also address ethics up front. You need to have plans for data privacy, algorithmic bias, and liability because these cannot be afterthoughts. And you need to have a system for education. How will you teach your workforce and your patients to be IT literate? You need to have a system for health information management education, digital communication, and data security. These need to be core competencies in your workforce and can't be added on. So the perfect vision of this is having every trainee have access to world-class simulation before touching a patient. Having every clinician with an AI-powered decision support that helps them make decisions and doesn't annoy them. Having every patient have access to expert critical care physicians regardless of where they're located. And every healthcare worker has technology that reduces the burden of their job instead of adding to it. We need to embrace these innovations while maintaining our core clinical competencies, and we need to invest in faculty development and infrastructure to support these changes. We need to develop evidence-based, adaptable curricula, and we need to ensure ethical stewardship with continuous evaluation. The workforce shortage is not going away, but for the first time, we have some tools that may actually help us manage it without sacrificing quality or burning out our people. Let me leave you with this. We are in the 4th generation of medical education reform. The first 3 were all about what we teach and where we teach it. This one is about how we teach it, and it's being driven by technology. But here's the critical point. Technology doesn't replace the human element of medicine. It can amplify it, and it frees us from the mundane so that we can focus on the meaningful. It extends our expertise so we reach more patients, and it creates safe spaces for learning so our trainees can be better prepared. The future of critical care training isn't about replacing doctors with robots. It's about creating better intensivists through smarter training. And that future, it's already here. We just need to have the courage to embrace it. Thank you.